We'll have the faculty kind of come up one at a time as they're presenting. But this is the agenda for the lunchtime. So we're going to kind of talk a little bit about this consensus meeting that we had in September, and then we kind of went over it with some other folks Wednesday. But this is just to kind of throw stuff out there, you guys. It's just information for the folks here. So we're looking at mostly geriatric low-energy pelvic fracture. So anybody at least 55 years old, which I'm getting close to that, so now I'm offended. With confirmed osteoporosis, low energy mechanism, and or confirmed osteoporosis, low energy mechanism. Acute was defined as less than 3 weeks from injury. Delayed was greater than 3 weeks, and or just looking at isolated pelvic rings. So kind of what a fair number of the studies that got presented in the last pelvis session was about LC1s in geriatric patients. And then using the Raman's classification for being more accurate with geriatric type or low energy fractures. And then a separate kind of statement about insufficiency fracture, since it's a distinct population and it's separate from the delayed group. So if you're not familiar with the Raman's classification, this is just a visual, but we're really talking about type 2s, and that's the gray zone. Type 3s and 4s are ones that you would normally fix. But this is the acute fracture, so less than 3 weeks. You have a low energy mechanism. You do your standard evaluation. And people asked about, could you use ghost imaging from the CT, since getting reproducible inlet and outlet images can be challenging for some x-ray techs. And then you see a pelvis fracture. You go down to classifying and stability assessment, which could be, we didn't really want to include examination under anesthesia, because the whole point, if you're not going to treat them surgically, is to not take them to the OR, then not treat them surgically. So a stability exam is, you can use, Joe Patterson has published, at least on a cadaver, and we're doing a prospective study using a trauma pelvic binder and a tensionometer versus, Josh Perry's lateral AP pelvis x-ray. Versus in the ER stress exam with an x-ray. Then you classify them, and like I said, 3s and 4s surgery, type 1, no surgery. If it's inconclusive from the imaging and you're concerned for a pelvis fracture, and they can't mobilize, then they get into evaluate with an MRI, and then they get back into the pathway. So a lot of this is based on functional assessment, including mobilization, which we'll go over. And if they fail a functional trial of mobilization, or we'll go into specifics, then at least discuss surgery. Insufficiency fractures are fractures that are over 6 weeks old and the patient is symptomatic. Advanced imaging shows non-healing, or I would say, non-healing or non-progressively healing fracture with related symptoms. Obviously, you're going to do metabolic workup and send them to the bone health team. And then depending on their symptoms and how they're doing, it's a discussion about operative versus non-operative management. And this is the pathway for the insufficiency fracture. So fairly similar, but these people usually come to clinic and present with that, and they're presenting to clinic typically because they've not improved functionally. And so most of the people that I see at this stage end up getting surgery. So the diagnostic protocol is standard radiographs, and whether that includes an inlet and outlet for you, it's just a standard evaluation, so that's why I have it in there. CT of the pelvis is to primarily evaluate the posterior pelvic ring, and then if same with previously, if there's an inability to mobilize or do the functional things that we asked the patient to do, MRI is to see if they're truly a type 1 or if they're really a type 2 by having MRI positive findings in the posterior pelvic ring. And then mobility pain with weight-bearing capacity, so we'll go into a little bit more of that. And then so 3s and 4s always operate, and that's what Professor Raman showed in his study out of Germany. The 2s are the gray zone, so if they're unable to ambulate from bed to hallway or bathroom unassisted without somebody helping them, it's okay if they're using a walker or cane or whatever the therapist is going to have them try, within 48 hours of admission, then it's a discussion for surgery. If they're wheelchair bound to begin with, then it's an inability to have bed mobility, so roll over in bed, side to side, sit up, tolerate being moved by the staff, or lift assist within 48 hours. And then basically you're confirming, if you don't see something in the posterior ring, it would be confirming that and confirming instability with the same things we talked about in the diagram. And then if they're in intolerable pain or immobilization pain with those things, then the discussion for surgery is had. So operative principles for type 2s would be failed non-operative management after 48 hours. So it's not a time frame like it's 48 hours and 48 hours and 1 minute they go to surgery. It's whenever, scheduling and OR availability and medical clearance allows. But the goal should be immediate full weight bearing with enough fixation to allow that, and highly recommend percutaneous, minimally invasive techniques. Contraindications to surgery are the typical ones: active infections, including osteomyelitis decubiti in the area, peripelvic soft tissue or bony infection, and then just not able to tolerate surgery from a anesthesia standpoint. Postoperative care, the goal is to help them mobilize, so immediate full weight bearing, don't delay weight bearing or have them try to do partial weight bearing. You kind of are going against why you're taking them to surgery. Multimodal pain management, try to minimize narcotics and delirium, and refer to bone health services, and then do your standard kind of postoperative follow-up in clinic. So this is just a summary of kind of from a CurvaFix standpoint. It's been out for 4 years, and high efficacy with low complications. So it's summarized as far as the types of cases, 50% low energy and insufficiency, 47% high energy, and then 3% oncology. And then the reported removals to date, total implant removal is only 1.7%. Removal due to loss of fixation is 0.4%. That's, I think I'm the only one that had that, and that was in a recalcitrant sacral non-union that failed after 2 years and broke all of her hardware, not just the CurvaFix. Removal due to in vivo breakage, that's during the case. That was early on, and I believe that was only 1. And then removal due to back out, 0.08%. And then the latest that one has been removed so far is at 2 years. And these are the references that were used for some of the things that we used in the consensus statement. But with that, we'll have Dr. Mehta come up and talk about a study that we got published.
This is on. There we go. Good afternoon, everyone. Thanks for being here. Really appreciate the opportunity to kind of go over some of the data that we have on CurvaFix. Some of it is early. You'll see some case reports as well. We're going to go do this relatively rapid fire. So this paper just recently was published in JOEI, was presented here in a video format last year at OTA. It's the early postoperative outcomes of a 3-center experience. And so from a background perspective, I think we all know and kind of heard if you were at the pelvic and acetabular session that there are issues with non-operative treatment, particularly prolonged immobilization and length of stay in terms of the hospital. There are also concerns with ORIF. There are risks associated with surgery. But with percutaneous fixation, we've been able to do more with minimal incisions, less risk of complications, less soft tissue dissection, and often better recovery for the patients. We also know that pelvis is complex 3D structure, right? It's not a nice, simple tibial long bone or femoral long bone where you have a cylinder and you're putting another cylinder down a simple cylinder. This anatomy is complex. It's curvilinear, and trying to match that anatomy can be challenging, particularly with nonlinear, with traditional straight screws. And so the curved implants allow for fixation around these osseous pathways that many of you have seen. And there's different fixation strategies that you have to think about as well, depending on where the injury is. And again, we heard some great sessions upstairs just a little bit ago about fixing the front and the back, particularly in some of these geriatric fractures, and in fact, fixing some of these geriatric fractures. And so different fixation strategies exist, and you can use the CurvaFix for posterior ring fixation, as you can see here. This is a great example. You can see the S1 tunnel. You can see the wire going around the S1 tunnel, so the S1 tunnel is protected, and you can see the curved wire followed by the curved screw, and the tunnels are safe the entire time. You can also do column fixation. This is an elderly person who's having difficulty mobilizing. And again, the ability to put an anterior column screw as well as a posterior column screw in an antegrade fashion to protect the columns and allow early mobilization is beneficial. So in our study, again, 3 centers, multi-center retrospective study, 111 patients amongst all 3 places. All the patients were made weight-bearing as tolerated. This is our early experience. As we've moved on, a larger percentage of our patients are weight bearers tolerated, but in this case, 81% of them were made immediate weight bearers tolerated. And at the most recent follow-up, which was at least 3 months for these patients, 50%, almost 50% were ambulating unassisted. The complication rate was quite low, less than 10%. 4 had intraoperative complications, including a malpositioned implant, a broken implant, and 1 bladder rupture. And then there were routine postoperative complications such as nerve palsies, wound breakdown, and infections. Again, this is the early experience with this implant. These are the first cases that we did amongst the 3 centers, so you can expect a little bit of a learning curve. So in conclusion, curved intermedullary implants are safe to use. They're a minimally invasive alternative treatment strategy, especially in curved corridors. And the early results suggest that immediate weight bearing does not lead to loss of fixation and allows for good healing. Thank you.
Thanks again for coming. My name is Matt Gardner. I'm in Springfield, Illinois. And this is another study on my first 52 patients. I've done about 150 now. And really, for me, the most important thing is, especially in these elderly patients who are not mobilizing, just like with hip fractures, we want to get these people up and walking as soon as possible. So I wanted to look at this and I wanted to see, early outcomes. But really what I wanted to find out is how long is it taking these patients to actually get up and mobilize with therapy. So these patients are starting out unable to get up and walk. I just want to say that first. So the overview, we have 52 patients. This is from 2 years. We use the CurvaFix Implant and again, evaluate the outcomes. So we were about 60% low energy, 40% high energy, and then the age is about 80 years old for low energy, and high energy is a little bit younger. I now give most of my high energy to my young, eager partner. So the duration of surgery, this has come down a lot. This is early, so there's a learning curve. We get better at this as we go on. The blood loss is fairly equivalent to what you would expect for like an intermedullary nailing for a hip fracture. And what we found on the time to ambulation for the older patients and the low energy was 25 hours. And I think what that is now is that's really the time that it takes for the patient to get to therapy. So we're not documenting this until the therapist actually sees them the next day. And I think if I had the therapist waiting for them to wake up, it would probably be a lot faster. I ask all my patients before surgery, can you roll side to side in bed? And most of them can't. And I tell them, when you wake up, I want you to do that. And I want you to tell me tomorrow how you feel. Not all of them, but almost all of them feel immediately better. So our complication rate was 21%, and that's a lot of it is just general complications you get with elderly patients. But the peri-implant failure, it was 1, and that was one that I had malpositioned. I didn't like it on CT, and so I went back a couple of days later and adjusted it. So that was the failure with that. There was really no difference in low versus high. In DVT, we had four cases. So here's 2 examples. On the left, we have a younger guy that wrecked his electric bike. On the right, we have a fragility fracture patient. So on the high energy guy, he's 46 years old. I think he went over the handlebars, and he has this. It's kind of a transverse posterior wall variant that's minimally displaced. And I did a traditional ORIF that was augmented with intramedullary fixation and let him walk immediately after surgery. So the second patient is an 83-year-old, and this is typically what you see on a CT scan. And when I first started this, I thought this was a little weird that I'm trying to fix this. But if you go and you stress this in the operating room, you can actually see how unstable that is. And so this patient gets front and back fixation. And then see if I can get both of these to go at the same time for time's sake. So this is just 2 weeks. I think the guy was 2 weeks on the left. I had trouble getting this very interesting lady to come back in, so that's about 4 weeks for her. But they're both walking fairly easily and pretty well.
Okay.
So the guy on the left is now about, I think he's 18 months out. And he says, well, he's a janitor. So he's like, I'm only doing 26,000 steps a day. So he's actually doing great. So CurvaFix, I think, is safe for both high and low energy fractures. It allows early ambulation and shorter hospital stays. And we're continuing to work on our studies. So thanks. So who do we have next?
So my name is Nick Quercetti. I practice out of Wilmington, Delaware. Today we're going to talk about a novel technique for anterior rank fixation. And to demonstrate this, I'm going to talk about a recent patient I had, 73-year-old, head-on collision, unrestrained driver, pretty bad right acetabular fracture, transverse posterior wall, and a right-sided SI joint injury with symphysis disruption. Multiple risk factors, one of them being his size. He's huge. Morbid obesity, he's also diabetic. He's had stents in the past, so high-risk patient. Because of the posterior wall fracture, I knew I was going to have to do a formal Coker-Langerback in the posterior aspect. I did not want to make a large incision in the front. I wanted to try to treat everything in the front percutaneously. He's got two injuries, the column fracture and the symphysis disruption. So using the curved implant, the CurvaFix, allowed me to address both of these with one shot and all small incisions. Day of the injury, my partner brought him back, put him in an X-fix with distal femoral skeletal traction. So you could see the acetabular component in the anterior column and the symphysis. So I brought him back a couple days later, stabilized the posterior pelvis, which helped reduce the anterior column in the front a little bit, but you can see the symphysis here is still quite displaced. So with a small incision in the mons, I was able to place a Weber clamp to get the anterior or the pubic symphysis with an improved reduction. On the outlet, you can see that it's still not perfect, but it's in the ballpark enough for me to get intramedullary fixation across the symphysis. 2.8 millimeter drill tip guide wire used for provisional stabilization, as well as a blocking wire. I added a second wire, as you can see here. And then just to drop the CurvaFix, standard starting point and trajectory for your antegrade anterior column fixation with your obturator outlet and obturator inlet images. Once you get your opening reamer, you place your steerable guide wire. In order to get this thing across the symphysis, you really have to cross right at the midpoint centrally on your inlet. If you're a little too posterior or a little too anterior, it can make it difficult. So I tell all my residents that you really want to be at that 50-yard line on the inlet. And another thing I do to really help with that is put a double bend on that wire. So the steerable guide wire has this tip that bends in one direction. So I'll accentuate that with a bend right there. And then I'll add a second bend or a double bend behind it just so that you can fit it through a bony corridor. And you can see here on this image kind of crossing right at that central 50-yard line on the inlet. And I'll follow it with the reamer. So get my wire down, follow with the reamer, pass the wire, ream. And in 50% of the patients, it's just like nailing a tibia. It goes pretty uncomplicated. The other 50%, you'll get your wire across, but then the reamer just quite can't make that turn. If the anterior ring has a bit too acute of an angle, the reamer will stop. And in that case, as long as you cross the symphysis with your reamer, the threaded end of the 7.5 millimeter CurvaFix is self-drilling, self-tapping. It can find its way up your contralateral corridor. I'll still add some of the blocking wires, and then once you get across that symphysis, you'll exchange your steerable guide wire for the 1.6 millimeter driving guide wire, and then start to place your implant. And in this patient, I did have to add a third wire as a blocking wire through a percutaneous incision just to help steer that implant up the contralateral corridor to prevent anterior escape. A lot of this anterior cortex in that contralateral parasymphyseal bone is quite poor, so that threaded head will want to escape, so the blocking wires really help with that. Other things you can do to prevent that are using elevators, a key elevator here in this example, a freer elevator, joker elevator in this example. Other people have used gouges and other types of periosteal elevators they've all been successful with, so you can get pretty creative. But this implant allowed me to treat the anterior column and the symphysis all in one shot with small incisions in a very complicated patient. And I was able to do my posterior approach and finish him up, and this is the final result. And these x-rays are 1 month out. This was like 6 weeks ago, so he was foot flat weight bearing on that involved side right out the gate, and fully weight bearing on the left side. So this is him a month after foot flat weight bearing.
Nick, can you just share, how are you making your incisions, just so that you know, are you doing just like small transverse incisions over the pubic body?
Yeah, so good question. So typically I will make a small transverse incision right over the symphysis, right over the mons pubis, just to get my guide wires. I'll put it directly over, not distal or cranial, just right over the symphysis. In this guy, I used the small vertical incision I had over his mons that I placed the Weber clamp through. He was large enough that I was able to utilize that to place my blocking wires.
John Michael Yingling, we're going to go over it's a technique paper we submitted. This is just a PowerPoint showing the technique for percutaneously fixing the posterior column with this curved intramedullary implant. We feel like there's a role for this in acetabulum fractures, as we alluded to. Here's a plastic model showing the trajectory from the iliac tubercle through the gluteal pillar down into the ischial tuberosity. And here's an AP and an iliac oblique fluoroscopic view showing what that looks like, on X-ray. In the technique paper, we used a couple cases. This was one of them. It was an 80-year-old male who had an acute acetabulum fracture on the right around a revision-style hemiarthroplasty. Also had a pelvic ring injury at different stages of healing, along with some cement augmentation into sacrum and spine. Here's some select CT cuts showing this protrusio, sort of associated with both column acetabulum fracture with no real connection. Imaging is important for using this technique. The iliac oblique view allows you to see the anterior and posterior margins of the posterior column, demonstrated by our lovely radiology tech here, and also the sawbones. Here's what it looks like on fluoroscopy. This is just at the step where we inserted our reamer. The other view, when you're starting, would be the obturator oblique outlet. It allows you to see the medial and lateral margins of your gluteal pillar, as demonstrated here on fluoroscopy. This is a little bit less of an outlet just because we had to have this patient's hip flexed for the acetabulum portion, or the intrapelvic portion. An AP image is important for determining the medial and lateral corridor around the periacetabular region, so demonstrated here and here. Superficial landmarks, you identify your ASIS and a few, 3 to 4 finger breadths posteriorly is where you'll find your iliac tubercle, which is the most cranial extent of your gluteal pillar and gives you access to the posterior column. Originally, we would make larger incisions just so we could ensure that we weren't going through the abdominal muscles, but you incise lateral to that where it inserts on the crest, so you can prevent from, insulting the muscle bellies themselves. Here's an example of the obturator oblique outlet where you can see you're in between the inner and outer table of that gluteal pillar after your entry guide wire and then entry reamer. And then here, getting the iliac oblique, ensuring that you're at least heading towards in between. Here's your posterior cortex of your posterior column, and then behind the acetabulum. This is the AP view now that your steerable guide wire is being inserted a little bit further caudal. And again, ensuring that you're in between your median and lateral margins here, and then following it again on your iliac oblique, ensuring that you're in the retroacetabular space and within the posterior column. Here's an AP view demonstrating after you had reamed and exchanged your wire and then placed the implant. And then the iliac oblique view showing the same. Here's the final fluoroscopic images showing what we did at the end of the case, showing everything. There's the inlet, outlet, views. There's a video of him immediately post-op, just showing that he was able to get up after several weeks of being completely immobile. He takes a few steps, and then at 6 months, he's completely healed. He still ambulates with a walker, but at least he's independent here. So just... Another important thing I wanted to mention was as you're using the guide wire, steering past the pelvic brim, oftentimes that's where the fracture is and it can exit there. You can use percutaneously or within that same incision, sliding under the iliacus muscle using a malleable or a cob or some other instrument as a blocking instrument to prevent it from passing there. Serendipitously, this person had a quadrilateral surface plate already that acted a bit as a blocker there. So.
Thanks, John Michael. Good techniques there to look at posterior column and jumping the symphysis, both which can be a little challenging and I think a really useful tool and application for the CurvaFix device. I'm going to go over my case series for my first nearly 40 patients. Sort of similar to Matt's study with a slightly less patient volume, but I think one of the things that people often ask about new implants and new techniques is, where's the data? Show me the data. Well, we're doing that. We're getting it. We're trying to get it out to everybody so they can see the different techniques, not only, but actually the results of some early case series. So we wanted to look at the use of CurvaFix, or the percutaneously placed intraosseous curved pelvic device, and try to help identify where it's most useful, what its findings are in this complex anatomy. The pelvis is a ring. It's pretty common. Everyone calls it the pelvic ring. We're still using straight screws in a lot of these places. So looking at some of the applications for more curve fixation to accommodate the native anatomy in these patients and trying to overcome some of these obstacles. So we did a retrospective review of my first 39 patients. This was all comers pelvic and acetabular fracture patients. No age limitations, so we looked at both geriatric and high energy patients. Standard patient demographics and history were also recorded. And our main outcomes were recording the time to weight bearing for all of these injuries, and also looking at time to union and recording any complications in the series. So in my results with the first 39, we had a mean age of a little bit more of a geriatric population, almost 69 years old. 2/3 were female, which I think if you look at where I practice in Cleveland, Ohio, we have a very high population of geriatric Caucasian females with osteoporosis that don't often see the sun. So that population was no surprise to me. We looked at pelvic ring injuries that had a chronic injury or two in this group, also acetabular fractures, and patients with multiple combined injuries. The mean time to weight bearing for all comers was about 3 weeks, 22 days, that they were able to comfortably weight bear without pain. They were all made weight bearing as tolerated from the get-go. So this would be someone who was comfortable ambulating, standing in double leg stance, and then performing single leg stance on their injured side with this implant. And the mean time to radiographic weight bearing using X-ray, which is challenging, and I'll mention at the end as limitation, was about 18 weeks. My typical patient follow-up is usually 6 weeks, 3 months, and 6 months. So most patients at 3 months had radiographic union. There was maybe 1 or 2 that sort of upped that average because I didn't see them back for then 3 more months. One of the more notable results, at least in my series, was that some of the more significant comorbidities such as osteoporosis, diabetes, and tobacco use did not affect the patient's ability to weight bear or their radiographic union. So to me, that is very helpful, especially in the geriatric pelvic fragility population. As Brett started off talking about, this is one of our focuses with this implant to get these patients up and going. So there was no increased complications or delay in weight bearing or union in that population. I did have to take one patient back to remove an S2 screw that had an S1 CurvaFix, which was my only complication to return to the OR that was unrelated to the CurvaFix. So just some of the data from the study, as I mentioned, the age was closer to 70 years old, predominantly female, predominantly Caucasian with a non-obese BMI. The average A1C in this population was close to 7, which was pretty high, and about 1/3 of them were osteoporotic. The tobacco use there is listed, either former or current, and a lot of these patients, like I had to laugh when I was going through this data because I can recall even about 5 or 6 patients to say they quit smoking, and it was like they quit smoking like a week ago. So that's what was recorded. But a lot of these elderly patients that have been lifelong smokers have sort of that reflection in their bone mineral density. And then the fracture patterns are also listed there. So you look at the event, time to surgery. We try to get everyone to surgery within 24 hours when it comes to patients that have an immediate indication. But again, circling back to Brett's talk at the very beginning, we're trying to give some of these patients, especially in the fragility population, at least 48 hours to try to get up and try to move. So I'm not surprised by that, about 48 hours to get to the operating room. We have a very similar protocol as the Missouri group does. Oh, I think yours is 72 hours. Yeah. We try to do 48 hours to give patients effectively 2 chances with physical therapy to stand and walk to the bathroom. If they can't do that, the correlation is that they can't take care of themselves at home. They can't perform personal hygiene. They can't then get from a couch to the refrigerator to feed themselves, and they can't go to the bathroom. So as long as they can demonstrate that, then they don't go to the operating room. In this group, so it's about 48 hours time. Discharge about 1 week. 7 days, and again, 3 weeks with weight bearing, and the rest of the union data is up there. This was from a abstract we presented back in January, so the follow-up time is now significantly increased, closer to 8 months, at least average in this group. Duplicated there, my bad. So again, if you look at some of the data, we have no significant differences in terms of weight bearing or radiographic union when you look at all of the demographic data that we collected and the risk factors, again, tobacco use, diabetes, and their fracture pattern, as well as concurrent injury. So we concluded that this curved flexible implant is safe. We didn't have any complications related to the implant itself, no implants backing out, no implant breakage, no failure of reduction, or delay in time of union. They were all able to achieve an early weight-bearing status. And despite some of these risk factors that we had listed there, the patients did not experience any increased complications due to that. So thank you for that. Pass it on to the next.
I'm Daniel Bravin from Springfield, Missouri, not Springfield, Illinois. And I'm going to present a case that kind of got me started on CurvaFix. I had a hard time coming around initially when I first heard about this implant. And it started with, for me, problems without solutions. So there were a couple of these, but I'm going to highlight one of them today. Parasymphyseal fractures. They're challenging to deal with, and the options are anterior column screws, infix, X-fix, ORAF. So all 3 of these are patients that I've treated with different techniques. So this is an example of one of the problems that I ran into. So I thought this looked good. Patient that I treated several years ago, a bicortical anterior column screw to a parasymphyseal fracture. At follow-up, this is what it looked like. So she displaced through it. Her screw loosened a little bit in the back. You can say maybe it needed more fixation in the back. I don't know that it would have made a difference in this case. But to me, this is a problem that I didn't have an answer for. So this is a more recent case that I've done, but it highlights kind of this problem. So this is a 63-year-old male. Motorcycle accident. He's an ex-professional dirt bike racer, and he loves telling everybody that. He had multiple other injuries, but he has this complete sacral fracture and bilateral superior inferior ramus fractures and kind of this saddle injury that you would expect from a motorcycle. So the options here, kind of like we talked about before, the anterior column screws, infix, X-fix, ORAF. And I thought this was a great opportunity to use the CurvaFix and show how beneficial it is in these type of situations. So these are just some fluoroscopic images from this case. So started by fixing the back, and then you can see the displacement in the ramus in the top left picture. So it's a pretty standard starting site for an anterior column screw. And then going down with the steerable guide wire, being able to manipulate it and kind of rotate it back and forth and kind of get it got down into the ramus there. And then one other technical thing here is in this parasymphyseal bone, especially in younger patients or not the non-geriatric patients, this can actually be pretty good, and it's hard to get that steerable guide wire out. So what I do is take a drill bit and actually push it down kind of as far as it'll go straightly, and it stiffens this construct a lot as you mallet that out. But then get that bicortical. I think a big key is being able to get it out bicortical, reaming bicortically to get the threads engaged into the parasymphyseal bone, and I try to kind of dock that anteriorly and caudally, and it catches kind of the intact bone of the fracture. And what you can see here, the difference is as it goes out, it then expands, and you can actually compress back through it as the proximal end of the implant hits the ilium. You just have to be able to measure it correctly so that it doesn't protrude too much there. But you can actually get some compression through the implant too, which is really cool. And you can see the amount of curve on that going through this displaced ramus fracture. So then similar on the other side, that side wasn't quite as displaced, but placed another CurvaFix there, and you can again kind of appreciate the dramatic dip that it does to catch that intact bone there. And so this is what it looked like at the final AP. And this allowed me to not do any incisions anteriorly. This allowed me to do all of it closed and be very comfortable with my fixation on this. And I tried to get the images, but it doesn't really show it very well. But I can tell you, when you stress this afterwards, every time I finish one of these, I stress it afterwards, and you can't even get it to move. You go on live fluoro and you try to move it, and it's not moving after this is all fixed. So this genius was going to weight bear as tolerated immediately anyways, whether I said not to. So I let him weight bear as tolerated right away. This is his 8-week follow-up, and he's already making a bunch of callus, no assisted devices. He came in at 2 weeks, asked for more narcotics, and I said no, and he was like, okay, I don't need them anyways, I just wanted them. So this guy, he's that kind of patient. But it's, yeah, so it was a very powerful implant for these type of fractures for me, and this is just a couple other ones that I've done with similar ones. Type injuries, and it just really changed the way that I've treated these fractures. I've become very comfortable letting all these patients weight bear as tolerated right away, whether they're elderly or younger, high energy injuries. This is kind of a myriad of different fracture patterns that I've used them for. So just one example of how this implant can really help you with fracture fixation.
Okay, so I'm going to just also highlight a case that I think CurvaFix has a lot of benefit. This is probably the most common type of case that I use this implant in. And so this is a 63-year-old female. She fell off her bicycle. She is the wife of the chief of surgery at our VA. She also has an open olecranon fracture and distal radius fracture. So she has some other injuries, and mobility and mobilization is going to be a problem for her. So you can see this doesn't look all too displaced. However, you can see the parasymphyseal fracture here. She also has a ramus fracture. And then if I'm going to tell you, which you'll see on the imaging, she has a crescent fracture back here with a sacral impaction. So let's roll through this quickly. You can see her iliac fracture, her sacral impaction. If you continue to come anteriorly, you'll see the root of the ramus fracture there, and then the parasymphyseal fracture on the same side. And even so, not so displaced, she has some markers of instability. And this patient is miserable. She hurts a lot. And she complains about her pelvis more than her open upper extremity injuries. So I stabilized this patient with multiple transduction sacral screws at multiple levels posteriorly. And you can see the morphology of her ramus. So she has quite a bit of curve. I think you can fit a straight implant here if you want to. However, my goal for her is to be pain-free and be able to mobilize, especially when she has other things going on. And so this is where CurvaFix has major benefit to me. And so you can pass the cerebral guide wire just like you've seen multiple times across this pathway. Again, to Dan's point, the guide wire is passed bicortically, so the bead's the end of the reaming portion, and that's where you're going to measure from. And I do think that bicortical fixation, particularly for these parasymphyseal fractures, is extremely important. Just like with screws, getting bicortical purchase is going to decrease your failure rate. And then from there, you can see the application of the curved implant as it fits this patient's anatomy. And also, you can navigate intersecting pathways. So this is just another plane of fixation for a posterior ring injury in this pelvic brim pathway or LC2 pathway in order to stabilize all the components of this patient. So this is our final construct. Post-operative CT scan, so you can see just how all these implants intersect with each other and their ultimate placements. And so before, my typical anterior fixation was solid 4 or 5 cortical screws. And so this is now a 7.5 implant that's fitting into this pathway that's now getting a 3-point fit. So I think that I'm fortifying the weakest point of my previous fixation constructs with a stronger construct. And that makes me confident that this patient can wait better tolerated, and this is her imaging at 6 months. And she has never once complained about this. She hates her upper extremity, but this is doing great. And so to me, this is the major benefit. You can fortify areas or navigate pathways that are otherwise more difficult to do to achieve your fixation with a very strong implant, or some maybe stronger than what you're using now. And so for me, that leads to early mobilization, and these patients do quite well. Back to Brett.
All right, so now this is the next generation of the implants. All the implants that you've seen have been the first version, the previous version. So we talked about and showed plenty of cases that show the flexibility or maneuverability of the implant prior to it being locked. And like I said earlier, it's 4 years of commercial use, thousands of implantations. The total is 65 degrees of curvature, controlled navigation for getting the implant in, and 25 degrees of cone angulation. And obviously, if this is too fast, like you're not catching details, the booth, you can definitely stop by the booth and they'll go through this with you. But now I think with newer implantation instruments, it's even more reproducible, less bulky. There have been some nice changes. So 65% smaller implant on the head. So you could see, like, especially on that anterior column implants, all of them were sticking out a little bit, and that's just because of the size of the proximal body. And now that's much improved with the lower profile design. There's multiple ways to get the starting wire in, and you can use more familiar, like if you use a cannulated drill for your iliosacral screws, that's an option, but you do still have to use the opening reamer. The implant length, especially for, you saw those posterior column implants, which I think is a big game changer for posterior column fixation. Sometimes 180 wasn't long enough, so now it goes up to 210, and you can really get down into the ischial tuberosity. And then there's a single-use flexible drill that functions as a reamer, and then improved locking feedback and experience. And so some of you who are at the lab may have already seen this, but definitely stop by the booth if you have questions. So this is basically it's a smaller head, so it's less palpable. So especially with the first one and this gluteus medius pillar implant corridor, like if you didn't countersink, the implant would be pretty prominent. And so this helps take away that need for the countersink. 45% reduction in instrument diameter. So it allows for this triple sleeve that you can pin in place and work through it for everything, which is nice. Threaded inserter, like an intermedullary nail. So it's try to do things to make it more similar to other devices that you use. And then you can also use the washers that are available, smaller or larger, to try to generate some more compression. You do get some compression when the implant's in and expanded, and then you tension the cables, and you can see that it withdraws. And on the depth gauge, it does show kind of what the expanded length is for each implant. So that's a nice additive as well. And then double the torque capacity for the 9.5 implant. And there's a stronger shaft design for that. So this is, again, I mentioned the 210 length. This is nice for the longer posterior column screws. Crossing the symphysis for parasymphyseal fractures, like you've seen some of the cases show. And it's just, one of the nice things is that if you, with just this device in general, say you're doing an anterior column screw and an LC2 screw, if you're kind of getting blocked by a straight implant, you can work around a start site that may not be what you would normally do, just because it allows more flexibility for implantation. This is the front cutting drill reamer, essentially, and it does look like that. It's very flexible, almost comically flexible, but it functions very well. And then you have a color-coded to show that you're fixed or locked or unlocked. That's additive. So instead of like the lines lining up, it's very visual, and then you can also feel it a little, have more tactile feedback. And then one of the things that I think is a big improvement as well in this next generation is the implant removal system. If you do have to remove it, I would say the instrumentation is more reliable to get the implant out, and just with the changes of design that we've had on the implant. So these are the indications for the pelvis, and this is kind of how we're capturing data. We have a registry going for people who are using the implants. And if you get to the point where you use them and want to partake in adding data to the registry, any of the CurvaFix folks that you work with can get you in touch with me and our research team. Thank you.